Okay, here we go. I'm gonna trace it now. Thank you.
Thank you, Carmen. Welcome, everybody. We will be starting in a few minutes. We're so happy that you're here today. Good morning, good afternoon, and good evening to everybody who's joining today for this Global Neurology Forum Track 2 session. My name is Camelia Lata, and I am the Program Director for Alumni Relations and Special Initiatives at the Global Brain Health Institute, where our sister site is based at the University of California, San Francisco. We're so delighted to have you here today for this very important discussion. This session is being recorded, and the title of our session today is The Impact of Trauma and Violent Conflict in Wartime and Brain Health and Healing. I'd like to acknowledge our technology team who is joining us today, Carmen Hart, Winnie Sue, who is remote today, and Andrew Filipoff. Carmen and Andrew are here with us helping with the technology, so thank you very much to them. Feel free to share any questions that you have in the chat, which will go directly to our speakers today. The Global Neurology Forum series has existed since 2018, and it is organized by GBHI and the UCSF Global Teleneurology Service. It is an opportunity for learning, for dialogue, and a very important discussion around changing the perception of neurological disease and innovation. Please note that the presentations are provided for educational purposes only. And like I said, this session is being recorded. A few words about our planning principles for this particular webinar. This webinar focuses on neuroscience, multiple geographies, and strategies we can learn from the arts. It does not focus on any one particular conflict in the world. This is not a political discussion, and we're very much committed as the full team of speakers and co-hosts and planners to an atmosphere of respect, listening, hearing diverse points of view, and collaboration in being in dialogue about health and healing. I'd like to bring in my colleague who co-leads this series, Dr. John Van Leeuwen. John is Assistant Professor of Neurology at UCSF. He is also the Executive Director of the UCSF Weill Institute for Neurosciences. John is a longtime faculty member with the Global Brain Health Institute. John, you are very welcome.
Thanks so much, Camelia. And thanks to everyone for joining us. I'm looking forward to our seminar today as we explore an important topic: the impact of trauma and violent conflict during wartime on brain health and opportunities for healing. We have a diverse collection of speakers from around the world that will guide us through many facets of injury and renewal in the midst of difficult settings. While for many of us, war may seem distant, its effects reverberate globally, shaping the lives of individuals and communities in profound ways. As we convene here today, we are reminded that war and its consequences are, unfortunately, not confined to history books. They continue to impact countless lives around the world, causing immeasurable suffering and disruption. Although most of us here are fortunate to live in regions relatively untouched by the direct trauma of war, tens of millions of individuals worldwide continue to endure the devastating consequences of violent conflict. from the ongoing crisis in Ukraine to the complex dynamics of the Israeli-Palestinian conflict, to the protracted instability in Syria and Sudan that have led to widespread displacement and trauma. These are just a few examples of conflicts that have destabilized communities and inflicted untold suffering on millions of people. Despite the weight of these crises, there's also some hope that we can draw from the people and societies that have emerged from violence and found ways to heal. In Colombia, for instance, the peace that was achieved after decades of armed conflict is one example that offers helpful learnings. Today, as Camelia said, is not focused on any particular conflict, nor will we go into the historical complexities of how these various conflicts came about. Rather, we want to use today's forum to focus on the consequences of war and refugee settings on brain health and opportunities for healing. As we go to the next slide, I'll briefly walk you through the agenda for our webinar today. Collectively, our speakers will present research that touches on a range of topics, going from acute injuries of war to adverse health effects resulting from forced migration. Importantly, we will also consider prospects for healing, resilience, and reintegration, and the role that the arts can play in bringing about transformative change. To help us cover various stages of injury and healing, we'll feature 4 different speakers. We'll hear from Dr. Gardner about acute neurological insults that can occur in war settings, in particular traumatic brain injury, implications such injuries may have for health later in life, and recent innovations under development for detecting TBI. Dr. Rousan will share research from a variety of contexts in which people are forced to live as refugees or encampments and the longer-term impacts this can have on mental health and cognitive function. We also aim to glean lessons learned from conflicts further in the past. We'll hear from Dr. Santamaria Garcia about his research working with ex-combatants from Colombia and insights related to a wide variety of biological markers that help us better understand the toll violence can exert, but also factors to consider for reintegrating people into society. And our final speaker and current Atlantic Fellow for Equity in Brain Health, Laura Calderon Cuevas, will speak about her work using music for healing after migration. But to kick off our seminar today, we have some opening remarks from Dr. Bruce Miller. Dr. Bruce Miller holds the A.W. Mary Margaret Clausen Distinguished Professorship in Neurology at UCSF. He directs the UCSF Memory and Aging Center and is the founding director of the Global Brain Health Institute at UCSF. In addition, he helps lead the Tau Consortium and the Bluefield Foundation. Precision medicine collaborations focused on developing treatments for tauopathies and progranulin-mediated forms of frontotemporal dementia. Bruce is a behavioral neurologist who studies the underlying mechanisms of neurocognitive disorders and is a world-renowned expert in the diagnosis and management of dementia. Bruce is also a global champion for bringing the sciences and arts together to achieve learning and new innovations. And now the video from Bruce.
My name's Bruce Miller. I'm very thankful to the organizers of this event, Camelia, John. Camelia asked me to say a few words about war. I'm a pacifist. I have been a pacifist all my life. I've demonstrated against wars, and so I have a point of view here. Let me start with quotes from others about war. The first come from Bob Dylan, and the second ones come from James Joyce. So in Chimes of Freedom, and some of you have heard me talk about this unbelievably prescient tune that was written in 1964, but you could listen to it today and it perfectly describes our world. Flashing for the warriors whose strength is not to fight, flashing for the refugees on the unarmed road of flight, and for each and every underdog soldier in the night, we gazed upon the chimes of freedom flashing. Don't you love that first line, flashing for the warriors whose strength is not to fight? And then Dylan talks about masters of war, and I won't quote the whole song. It's fierce, and I think it's correct. And talking to these people who make guns and weapons of war, Dylan says, you fasten all the triggers for the others to fire. Then you sit back and watch when the death count gets higher. You hide in your mansion while the young people's blood flows out of their bodies and is buried in the mud. Okay. And then Joyce, this one's a hard one to wrap your head around. And I think about this idea constantly. And I'm not sure whether he's right or wrong, but I think the world would be better off if people followed this mantra. Jefferson Airplane put this into a song of theirs. You die for your country, I say, let my country die for me. Up to the present, it has done so. I didn't want to die, damn death, long live life. So that's his idea about war. And then he says it again. I resent, in a different way, I resent violence or intolerance in any shape or form. It never reaches anything or stops anything. Revolution must come on the due installments plans. It's a patent absurdity on the face of it to hate people because they live round the corner and speak a different vernacular, so to speak. So those are words of people much more profound than me about war. You're going to hear an amazing set of talks today about how people have stepped in and tried to make a difference for the victims of war. Raquel has thought, Gardner has thought long and hard about the horrible trauma that happens to people who survive the war, the head trauma in particular, how it changes their lives in a terribly tragic way, how it changes the lives of people who live with them and in a magnificent, beautiful way, take care of them. You're going to hear from Tala Rousan, who talks about a different sequela of war, which is the forcing of people to become refugees. The many millions of refugees across the world have become refugees because of wars in their own countries. And think of the unbelievable trauma associated with wandering without a home as a refugee. So there are the deaths, the traumatic brain injuries, the psychological sequela of being asked to go to war and kill. And sadly, many of the mass murders that we see in our countries are associated with people who have learned to kill in a formal way within the armies. And then, of course, there is the massive side effects on the families in which these people live and the illnesses that loved ones get as they care for the sick and dying. So we're going to talk about the science of war. I wish there was no science, because if we didn't have wars, we wouldn't need a science for this, but we need it. And I will also say this is not a political forum for arguments, for description of who and whatever conflicts are going on across the world are right or wrong. I think we have our own points of view about this. But I think another role GBHI can play in the future, it's a great role that Chuck Feeney has played, is to try to bring peace to conflicts. And I think it's something we should think long, hard, and dearly about as we approach the next decade of our programs. Thank you for the opportunity to give my very strong but somewhat idiosyncratic views about this forum today.
Thank you, Bruce, for those heartfelt comments. And now we'll turn to our first research talk of the day. Dr. Raquel Gardner is a neurologist and director of clinical research at the Joseph Segal Neuroscience Center, Sheba Medical Center in Tel Hashorm, Ramat Gan, Israel. Raquel was previously an associate professor of neurology and a faculty member in UCSF's Memory and Aging Center, the San Francisco Veterans Affairs Medical Center, the UCSF Center for Population Brain Health, and the Global Brain Health Institute. Her clinical research program focuses on traumatic brain injury, aging, neurodegeneration, disease, and is currently funded by the NIH, the U.S. Department of Defense, and the Binational Science Foundation. She's a transforming research and clinical knowledge in traumatic brain injury investigator and a member of the executive committee of the International Initiative for Traumatic Brain Injury Research. Welcome, Raquel. And I believe you're still muted, Raquel. Oh, it was. Try now.
How's that?
Yep, perfect.
Great. Okay. Thank you very much to GBHI and the organizers for inviting me to speak. I'm going to give just a overview of some of the prior work that I've done and some of the more recent work that I'm doing now. The agenda will cover TBI, traumatic brain injury, and neurodegenerative disease. Then I'll focus on war-related TBI and then a bit about future directions. So recently, while I was still at UCSF in 2021, I collaborated with Christine Yaffe and others at UCSF and the Center for Population Brain Health on a meta-analysis covering 20 years of literature looking at the risk of dementia in association with a single traumatic brain injury. And we identified, as many previous meta-analyses had identified, that indeed there was a significantly increased risk for all-cause dementia that was associated with TBI across these many studies, 41 risk estimates, and 7.7 million individuals. In previous work led by Deb Barnes, also with Christine Yaffe, using nationwide Veterans Health Administration data, we saw that even traumatic brain injury without loss of consciousness was associated with increased risk of dementia, specifically in military veterans. There's also evidence that repeated TBI, blast TBI in particular, can be associated with a unique neurodegenerative tauopathy known as chronic traumatic encephalopathy, or CTE. This was first characterized or most recently recharacterized in the early 2000s and received a lot of attention after this disease was identified in professional American football players. CTE has since been described in a variety of contact sport athletes, autistic children with repetitive head banging, and military veterans. However, the consensus neuropathological diagnosis and criteria are now fairly well established and are now even in version 2.0. There is a possible specific pathology that has been seen in some military personnel with blast exposure that was reported by Dan Pearl, and he calls this pathology scar border forming astrogliosis pathology, which you see on the GFAP stain. This is actually not tau, it is not CTE, it's something else. However, whether this is unique to blast is still debated. Other neuropathologists, including Willie Stewart in Glasgow, report seeing the same pathology in very severe impact TBI. What's interesting about the cases from Dan Pearl is that these were in blast TBI, with a negative head CT, not severe TBI. So this is something which is still an evolving story. And so more recently, I've been learning about war-related TBI in particular. So my previous work was predominantly in civilian TBI, or long-term effects of TBI in veterans. It turns out, though, that most of the TBI in veterans occurs in post-deployment or post-return to civilian life. And so war TBI turns out is quite a different thing. And what I'm learning is there are really two main flavors. One is visible injury, and the other is invisible injury. So by visible in wartime, we're seeing a lot of severe penetrating traumatic brain injury. Invisible injuries, also known as concussion, mostly from blast, are the injuries where if a patient gets a head CT, it's generally negative. You don't see anything on the head CT, and you might also not even see anything on the MRI. And so these are just a couple, this is one example on the lower left of one patient who had a very tiny piece of shrapnel that hit just under a helmet at a very high speed and actually penetrated into the brain and landed right in the middle of the thalami. The entry wound was just this tiny little dot. So I thought I would show that as one example of a penetrating TBI. Luckily, this patient was up and walking around just a few days later. The invisible injuries are something that we learned a lot about from the US wars in Iraq and Afghanistan. All right, so just a little bit about visible TBI, the penetrating TBI. So this is defined as a head injury with violation of skull and likely dura and brain by a foreign object. There are different types. Here are just a few specific examples of a penetrating injury where you have the foreign body that penetrates into the brain, a perforating injury where it's a through and through injury of something that passes through the brain. From side to side, and then a tangential injury. And then sometimes with tangential, you'll have skull fragments that perforate into the brain and contusion. I learned a lot about penetrating TBI from Guy Rosenthal, who's a neurosurgeon at Hadassah, but also at UCSF, who works closely with Jeff Manley and was trained by Jeff Manley at UCSF. And so what Guy has taught me is that the stepwise advances in treatment of PTBI read basically like a history lesson of war, because luckily penetrating TBI is not extremely common in general, but we see a lot of it during wars. And so this timeline essentially shows sort of the major advances in clinical management of these really severe brain injuries over time as technology advanced and could be applied in these traumas. Here is essentially what happens when you have a really high velocity object penetrating the brain. This is a block of jello that's showing the pressure waves that come out from that object that penetrates the brain. And just to give you a sense of the pathophysiology that is occurring in the brain when you have a high velocity object that's penetrating. And so it turns out that because there's not a huge amount of trials or evidence in PTBI clinical care, it's mostly based on expert consensus. And luckily, new guidelines were just drafted at NIH in September 2023, which was just in time for us, because less than a month later, we were inundated with a number of these injuries at my hospital and several other hospitals in my region. And so Guy Rosenthal pulled together a bunch of other centers, these 4 centers listed here, and said, hey, we have an opportunity to learn a lot more and continue to advance clinical management in this relatively rare condition. Let's get together and develop some common data elements that we will all collect so that we can share data and we can learn from each other, and we can also even share data with other countries and regions that are experiencing conflict. And so that's what we did. We developed these common data elements that we're all collecting on these very severe injuries in our ICUs. And we have shared these forms with others, including a neurosurgeon in Ukraine and in the US military. It may seem obvious to people in dementia research that everyone should measure the same stuff, but it turns out that for penetrating TBI, this hasn't yet been done, while it has been done for other types of TBI research. So moving on to the invisible TBI, the definition of invisible TBI, and I'm specifically not saying mild TBI because it turns out that that is a term which is falling out of favor, because if you have a chronic disability from a mild TBI, then you probably don't appreciate having it be called mild. And so the preferred term is moving towards just saying, okay, it was a GCS 13 to 15, meaning when they first came to the hospital, they didn't have a huge amount of symptoms and the head CT was negative. And this again was the signature injury of US wars in the Middle East. Most people do recover, but many, and especially those with blast TBI, have chronic and even progressive disability. Due to the US wars in the Middle East, the standard of care in the US military today, as a result of a lot of bad press in the early 2000s and a lot of action and spending on the part of the US military, is immediate diagnosis, patient education, and symptom management of any possible concussion. And they're very, very committed to this. But this is not the case in most countries in the world, and it's even not the case in US civilian healthcare systems and most civilian healthcare systems. The truth is, invisible brain injury is very underdiagnosed. And so what we saw in the first over a 10-week period of time at my hospital When we pulled ICD codes of all injuries that were admitted to the hospital, we saw that very few had a diagnosis of traumatic brain injury, less than 6%. And so we asked, well, where are all of these invisible diagnoses? And it turns out that, as expected, they were being underdiagnosed, which is common worldwide, except really in the US military. And so we put together a task force, raised awareness for these invisible injuries. We built a multidisciplinary team, and we are now doing our best to advance clinical care while simultaneously advancing scientific knowledge. We've developed and validated a specific screen to implement here. We are working on adapting Kate Pocin's Dementia Care Eco CTN model to coordinate multidisciplinary follow-up care for discharged patients. And we are building research infrastructure across various departments. So how do we screen for war-related TBI? So it's fairly straightforward. You identify a potentially concussive event. You find out what happened, what was the mechanism, and you establish, was there a blow or jolt to the head? It turns out that having a blast wave on your body, feeling that blast wave, is considered a blow to the head because the blast wave is also passing through the brain. And then once you've established that there was some kind of head trauma or blast wave to the body, then you ascertain whether there was an alteration of consciousness, such as confusion, or repetitive questioning or disorientation, or an actual loss of consciousness or peritraumatic amnesia, a portion that the patient does not recall. And if so, for how long? And that helps you grade the severity. And that's the clinical diagnosis of traumatic brain injury. And so we deployed this screen in our rehabilitation hospital in those with polytrauma from the war. And what we found was that overall, and this is reflecting about 50 that were screened so far, 60% met clinical criteria for mild TBI. And these were all patients who weren't admitted because of brain injury. These are patients with body trauma. And among those who did not have blast as the mechanism of injury, less than a quarter were diagnosed with TBI, while as those who had a blast exposure as their mechanism of injury, more than 75% met clinical criteria for TBI. We've been measuring symptoms using the River-Mead post-concussion symptom survey, and are finding that our diagnosis has some face validity, and that we see evidence of a correlation between TBI diagnosis and the burden of symptoms on the post-concussion symptom screen. And this is just showing a graph with no TBI, non-blast TBI, and blast TBI, and then another one with no TBI, TBI with no loss of consciousness, and TBI with loss of consciousness. We see a similar association when we look specifically at patient-reported cognitive problems, and there are 3 items on the River-Mead screen that ask about cognitive symptoms. However, it turns out many symptoms of acute stress reaction can masquerade as symptoms of concussion and vice versa. So this can be a big challenge, especially if someone's in a very traumatic situation when they are injured. They can have dissociation, they can have many psychological symptoms that could certainly meet criteria, clinical criteria for TBI. So this is really difficult. And wouldn't it be great if we had a simple blood test to diagnose brain trauma specifically? And it turns out that luckily we do, and we have one even that was FDA approved just under a year ago in March of 2023. And here's the FDA approval letter. So this is a blood test that combines 2 blood-based proteinomic biomarkers, GFAP and UCHL1, that was initially discovered in animal and human studies at University of Florida by Kevin Wang, and then from the early 2000s until now went through a lot of stages of development and research with a lot of collaboration from the US military and Department of Defense, and ultimately is now available on 2 clinical laboratory platforms. And so these 2 markers, one is a neuronal cell body marker, one is a gliosis and glial injury marker. And what's really interesting about them and why we need 2 of them is because UCHL1 rises within minutes of traumatic brain injury and then falls within just a few hours. So by 12, 16 hours, it's already basically finished. GFAP, however, takes a few hours to rise, peaking at more like 10, 12, 16 hours, and then may stay elevated for up to a day or even 2 weeks in the most severe of cases. And so with the two markers together, you can identify brain injury from the moment of injury, from minutes post-injury until up to a day or more. And so here's just a little bit of data on some of the published studies demonstrating the accuracy of this test for discriminating patients with TBI who had positive head CTs for intracranial hemorrhage versus didn't have a positive head CT, or TBI from controls who were orthopedic controls or healthy controls. And this is just to demonstrate that even patients with TBI who have a negative MRI still have an elevation on this blood test in the GFAP. And so the test is in fact more sensitive, we think, than head CT, more sensitive than an MRI, and it's possibly more sensitive even than the clinical diagnosis. And so we see that there's a slightly higher level in orthopedic controls, right, who were screened negative for symptoms of TBI. And so we have brought this test now just recently to my hospital, and we're in the validation phase in our clinical laboratory. These lovely ladies are working on validating the test on our platform in our laboratory. And we have already implemented the test now in any emergently evacuated war injury who arrives to our ED, and are planning clinical concussion screen, acute stress screen, the TBI blood test, and then follow-up screening to establish whether they have post-concussion syndrome or PTSD and identify whether we can use this as a predictor. So to wrap up in the final minute, an emerging area which is really important is this the exposure that people sustain from low-level blast. And this is something which has gotten a lot of attention lately in the United States, in the US military. Military personnel who shoot heavy artillery and breach buildings sustain a lot of repetitive low-level blast, and that cumulatively over time, there's evidence this does in fact lead to brain injury. And so this is a really important future area to understand what is a safe amount of blast over pressure, and is there anything we can do to better protect the brains of folks that are unfortunately fighting in conflicts. So I think I'm basically out of time, so I will wrap up. There are a couple of pearls that I have learned, and many people to thank. Of course, my team here at Shiva, Orit Lesmansegev, who provided head CT images for the talk, and many, many people, including at UCSF and around the world. Thanks.
Thanks so much, Raquel. That was wonderful. We'll now go to our next research context talk, and our featured speaker, Dr. Tala Rousan, who is an epidemiologist, physician, and an Atlantic Fellow for Equity in Brain Health and the Global Brain Health and at the Global Brain Health Institute. She's an assistant professor and founding faculty at the Herbert Wertheim School of Public Health and Human Longevity at the University of California, San Diego. Tala is also affiliate faculty at the Division of Geriatrics at UCSD. Tala's ongoing research focuses on designing evidence-based programmatic interventions and health policies that reduce health disparities, centering a human rights approach and using innovative technologies to promote health and longevity. In San Diego, Tala is leading a hypertension self-management intervention study among Middle Eastern and East African refugees, as well as multiple projects studying dementia and barriers to care among recently resettled Syrian and Iraqi refugees, two of the fastest growing foreign-born populations in San Diego. Internationally, she is leading a study examining the impact of encampment on cognition in Jordan and Lebanon, and is part of a study assessing hypertension management in Peru, Malawi, and Cameroon. Welcome, Tala.
Thank you so much. Thank you for having me. Today's talk is looking at disparities in cognition and cognitive function among aging refugees. And like Bruce said, sometimes we wish we weren't doing this kind of science, but here we are looking at the health of refugees who are now at an unprecedented number in the world. We currently have 110 million forcibly displaced people worldwide. That is 1 in 74 people who are forcibly displaced. These are the highest ever recorded numbers in recent history, and these numbers are only projected to increase to 1.2 billion by 2050 due to the raised inequality in the world, the high numbers of conflict and war, and also climate change, which is expected to displace more and more people. The majority of the world's refugees are actually residing in the global south, in countries like my country of origin, which is Jordan. In Jordan, 1 in 3 people is a refugee. The US has historically resettled more refugees than any single country, in fact. So refugees reside here for generations in the US. And about 60% of all world's refugees come from only 3 countries, which are Syria, that tops the list, Afghanistan, and Ukraine. It's very important also to understand the different terminology used to describe displaced people. A migrant is a very generic term for any person that moves from one country to another. I am a migrant from Jordan to the US. An asylum seeker is a person who has formally submitted a request for asylum, but have not yet completed the asylum procedure. So their request for asylum is pending. And as we know, we are here in California bordering Mexico, where we receive a lot of asylum seekers as well. A refugee, however, is a person who has completed the asylum procedure with a positive outcome and has been granted protection by obtaining a refugee status. And today's talk is really focused on refugees, since they together make the largest number of displaced people worldwide. So I'm a physician scientist, but I'm a public health practitioner as well. And this is how we like to think of health as public health professionals. It's the socio-ecological model, meaning that your health is really affected by so many factors, including social and community influences, living and working conditions, and more generally, the general socioeconomic, cultural, and environmental conditions. And in fact, migration is a social determinant of health that is oftentimes overlooked. As you can see, it cuts across all these layers. So when someone moves from one country to another, just by being a migrant, which is again this generic term, their health is impacted in so many ways. So today we will focus on forcibly displaced people who have additional exposures beside being a migrant, which are usually mental health exposures and other exposures related to being exposed to war and the lengthy migration journey between different countries before arriving to safety. So older refugees are either people who are displaced when they're above the age of 60, let's say, and those make up about 3 to 5% of registered refugees through the United Nations High Commissioner for Refugees, which is the main entity that looks after refugees worldwide. However, a person can be aging while displaced, and we're seeing also high numbers of people who are aging as displaced, the highest ever recorded. A life course approach is extremely important as we think about aging refugees, right? When during their life have they been displaced, what have they been exposed to, really impacts the way they age. And currently also, more refugees are aging in refugee camps. Most of my work globally is in refugee camps, such as the Zaatari refugee camp in Jordan, which is the largest refugee camps for Syrians worldwide, and the largest refugee camp in the Middle East. In fact, a lot of people don't know this, but the average stay for a refugee in a refugee camp is 15 years. So 15 years of one's life is spent in an encamped space, such as a refugee camp. I want to walk you through the research on refugee health, specifically on older refugees. So most of the research, again, is on immigrants' health or migrant health, this generic term that you hear about in the news often, which is a safe way to describe someone who's moving from one country to another. And we know that there is something called the healthy immigrant effect, for example, which is an advantage, a health advantage for immigrants in general when they move here to the US. However, we're seeing that actually this advantage does not exist for refugees. So again, that's why we are thinking of refugee health as a separate entity, not within the immigrant health research. We know that there is generational trauma that transcends generations in refugees. We know that there is a term being used more and more now, which is a second generation trauma for our second generation refugee, for refugees who have been born in the US here to parents who are refugees. And we're seeing there is, for example, parents who are likely to be depressed, who are refugees, their children are likely to be born also, who are born here in the US, are likely to show signs of depression and other mental health issues, as well as other health disparities. However, this field is growing, and we're learning more and more as we study the offspring of refugees who are born in the US. There's almost nothing known about the risk of dementia in refugees, in fact. Most of the research that has been done on dementia in war-impacted communities is done on veterans. And veterans, we know, were found to have an increased risk of dementia. In fact, veterans who had PTSD were at twofold higher risk of developing dementia in a 7-year follow-up period. And this is work that has been done by Christine Yaffe and others, which made me think about studying dementia among refugees. There's a huge research gap in the field. In fact, we're currently conducting literature review and meta-analysis. Unfortunately, I don't think a meta-analysis is going to be done because we are not able to find research on dementia among refugees that quantified this risk. There are major disparities in this research with oversaturation of mental health evaluations that mention cognition but actually don't test it. And most cognitive tests have not been validated for refugee populations or even low literacy and linguistically diverse populations such as the Arabic-speaking population. Our findings are showing in this literature review that lower cognitive scores are attributed to environmental factors. So we need to be careful not to attribute this to communities. In fact, studying the environment, such as encampment, for example, is extremely important, which is the work that I will share with you next. Post-traumatic cognition ameliorated with higher social connectedness. And we know that protective factors that modulate the effect of discrimination and post-traumatic adjustments exist. Also, social cognition is the most studied of the cognitive domains. And we found that clear impaired social cognition across age groups, but most on children. So again, there's very little literature that looked at older or aging refugees. Also, one of the biggest barriers to doing this work is a lack of funding. We actually just published this paper in JAMA that showed how much NIH has funded refugee health for the past 30 years. And of course, we found that most of the funding was focused on mental health rather than chronic conditions, for example, and other things. And that's why I'm hoping to produce more research in the area of dementia, hypertension, cardiovascular disease, and all those risk factors that we know increase one's risk of dementia. So my work is between Jordan and San Diego, given the context that I described to you, which is that Jordan is a top refugee hosting country, and San Diego also, where I sit here, is one of the largest refugee resettlement hubs in the USA. In fact, it's the second largest resettlement city in the United States, where we receive refugees from all over the world. Currently, we're doing work in Jordan to look at the associations between mental health and cognitive function in refugees from Zaatari refugee camp, which is home to about 100,000 Syrian refugees. And this is funded through the Global Brain Health Institute as well as the Alzheimer's Association. In San Diego, I'm funded through the NIH to look at interventions to improve blood pressure control to prevent cognitive decline, which we know that uncontrolled blood pressure is a big problem among refugees. We also are looking at barriers to dementia care and assessment, and how we can intervene upon these barriers. These are some of the pictures of our work in Jordan. As you can see to the left here, this is Zaatari refugee camp. Again, the average stay of a refugee in the camp is 15 years. And the Zaatari refugee camp was established in 2011 when the conflict in Syria started. I want to share with you some of the preliminary findings of my pilot study in Zaatari refugee camp. And this is the first time I'm sharing it, so I'm really excited. Our project, again, wanted to look at associations between PTSD, complex PTSD, depression, anxiety, and cognitive function. And it took place during the pandemic, so I will share with you also lessons learned on how to test for things when we are all working remotely. In fact, one of the biggest barrier I found to conducting this work is that we don't have a single test that can collectively assess all aspects of cognitive function in this vulnerable group. A lot of the refugees that stay in camp have had interrupted education, don't have access to school, or are illiterate. And assessing, we know that this comes with a lot of barriers to assessing cognition, using the tools that we usually use, such as the MOCA and others. In fact, very little exists in terms of validation of these tools in Arabic and for populations such as refugees. So we were thinking of using a tablet-based testing, the TabCat. However, because of the pandemic, we couldn't deploy any of these methods and decided to use a telephone-based survey. In fact, something that I've learned is that refugees all have access to a smartphone and internet, and they prefer that over food to stay in touch with their family members who are doing these long and strenuous migratory journeys. So we decided to use a telephone-based survey which assessed demographics, post-traumatic stress disorder, depression, and a tool that was used by a colleague of mine at the University of Michigan that was validated among Arabic-speaking populations that looked at SIRAD delayed recall, animal fluency, and digit span forward and backward. And these are some of the preliminary findings. We're learning that the population in Zaatari, and I have to say that only 15% of Syrian refugees in Jordan reside in camps. The majority are outside camps, and we were really trying to get a sense of the situation among refugees in camps and outside camps. The population does have low literacy and education access, as shown in the table. We decided to look at refugees in camps, refugees outside camps, and use the closest that we can get to a perfect control, which are Jordanians of similar backgrounds that reside around the camp. And the camp is in the northern side of Jordan, which is more rural. We found that the differences between controls exist. Refugees living in camps tend to be of lower education and socioeconomic status. We found that all the cognitive domains that we looked at and we mentioned, the delayed recall, the digit span, animal fluency, all of them are actually alarmingly low. In fact, among Jordanian control, it was 7, and the normal score is between 1 and 10. So 7 is good. However, as you can see here, it's 4 in refugees living in camp and 4 in refugees living outside camps, which is telling us that definitely just by looking at prevalence, there is a lower score, at least for memory and delayed recall. Depression scores indicate that 41% of the controls meet criteria. And for us, this was also shocking to know that Jordanians who live in the area are showing signs of depression. 51% of those living in camps were depressed, while 62% of refugees outside camp meet the criteria of depression. And this is really a high percentage compared to a meta-analysis that showed that among refugees in general, depression can reach up to 50%, but seeing 62% of a prevalence of depression among refugees outside camp was kind of alarming. Now, the score of under 17 for animal fluency is a concern. Our median for control is 6, which is also very low for animal fluency, and in camp was 4, outside camp was 5. For the digit span, outside of camp performed significantly worse for forward and backward. However, performing better on backward is very rare, and it's an unusual finding that across all groups, they all perform better with backwards. So again, these are all signals for future work that can look into this in depth. These findings indicate the need for the development of a better battery for Arabic-speaking populations or low literacy education groups and refugees. And here we can see again that people living outside camps show higher sign of depression, which was for us against what we thought. We thought that people who are living in camps are more depressed and have poorer cognition, but we're seeing actually that those who live outside camps have more depression and poorer cognitive function. And this could be a reason to think of the difficulties of living in a high, in a low to middle income country, but actually Jordan is very expensive to live in for refugees to kind of navigate jobs and life outside camps. While inside camps, there might be higher community ties and social interactions that might explain what we're seeing. Switching gears to working with refugees who are here in America, we have looked at the American Community Survey, the census data, which gives us some idea of ethnicity and country of birth. And this is some work that we published in the Journal of Gerontology that actually looked at data that dates back to 2000, so 19 years of data among Middle Easterns. And we found that foreign-born Arabs reported higher odds of cognitive difficulty compared to US-born Arabs, and that migrants who are born in areas of conflict, who migrated during conflicts in their countries, such as Iraq, Somalia, and Syria, report worse cognitive function. And we know that subjective cognitive decline is also indicative of true cognitive decline. We also do a lot of mixed method research, a lot of qualitative work among refugees who are from Afghanistan, Syria, and Iraq here in San Diego. And we learned that there are very specific exposures and characteristics of these communities where, again, going back to the socio-ecological model, many layers are impacted in a unique way, which gives us insight on policy and intervention design as we think about these aging communities here in California. We found that perceived discrimination impact mental health. And of course, there is so much community wisdom to be shared. Take-home messages: mass displacement is a global public health challenge affecting brain health. Cognitive disparities related to forced displacement exist and are severely understudied. And there's a need for longitudinal research among refugees. Thank you so much.
Thanks so much, Tala. Much to think about there. And just want to provide a reminder that we're going to hold all questions for our speakers until the very end when we get to our panel discussion. So next, we'll now turn to the next portion of our session today, emerging research and practice. And our next speaker, Dr. Hernando Santamaria Garcia, who goes by Nano, is a psychiatrist and an Atlantic Fellow for Equity and Brain Health from the Global Brain Health Institute. Nano is the director of the PhD program in neuroscience at the Javerian University in Bogota, Colombia. Nano is also a researcher and clinical professor at the Javerian University. He works to promote public policies for brain health in Colombia and other Latin American countries based on the interactions between epigenetics, environmental factors, and social determinants of health. Nano has been the chief editor of the Colombian Journal of Psychiatry and is a leader of the regional network, the Latin America and Caribbean Consortium on Dementia. Among his ongoing research is Nano's pilot award study, Brain Health in Individuals with Exposition to High Violence in Colombia, from an awards program supported by the Alzheimer's Association, Alzheimer's Society, and the Global Brain Health Institute. Welcome, Nano.
Thank you. Thank you so much for having me. So today, I'm so happy to have the option to share with you some of our results when we try to see and study the effects of violence and armed Colombian conflict in brain health and mental health in individuals exposed to intense and chronic degrees of violence. So as you know, Colombia has one of the long-lasting conflicts across the world. We have more than 7 decades of armed conflict due to multiple origins. We have land ownership issues, we have structural social disparities, as you know, we have difficulties for some individuals to access to political participation, we have social exclusion, we have poverty, systematic poverty. And we have a lot of agents involved in Colombia conflict. As you know, we have paramilitary forces associated with left-wing forces, but also right-wing political party. So moreover, we have an involvement of the Colombian army in some of the problems associated with violence, but also, you know, we have a long-lasting history associated with narco trafficking issues and narco trafficking agents. That kind of problems has left us with staggering numbers revealing the atrocity of the war that we experienced in the last 7 decades, with more than 8 million individuals who suffer forced displacement, more than 300,000 mortal victims associated with the armed conflict in the last 4 years, and more than 30,000 victims of kidnapping, revealing a very terrible panorama associated with conflict. We have an opportunity recently in 2016, we have the option to arrive to a peace agreement between the Colombian government and the FARC, which is one of the biggest organizations, left-wing organizations involved in the armed conflict. And as a consequence of this peace agreement, we had the opportunity to investigate further the social and health effects of armed conflict. Right now, we have some preliminary evidence revealing that there are multiple health consequences in individuals exposed to violence, not only victims, but also people that assume a combatant role, I mean soldiers, but also ex-combatants for left and right-wing parties. However, to the best of our knowledge, so far, few studies have systematically assessed brain, mental, and health factors associated with the exposure to violence due to armed conflict in Colombia across the lifespan. So based on that, we have worked in 2 biggest projects. One of them is to try to capture the differences in mental and brain health between individuals exposed to intense and chronic violence in Colombia, and trying to see how those effects could be moderated by the different lifespan stage of the individuals. To this end, we assess information coming from national surveys, the population and national surveys that we have in Colombia. We have a national mental health survey developing in 2015, and we have also some pre-existing data from the National Hygiene Survey taken from 2016. More than 20,000 individuals in the National Hygiene Survey, and we analyzed more than 15,000 individuals in the National Mental Health Survey. We have a very, very important assessment of the different diverse ethnic and racial groups in Colombia, because this is an study, or those studies has systematically randomized and representative sampling processes accessing to different zones in our country. We assess different factors associated with healthy aging, including, of course, social determinants of health. As you know, Livingstone's and the Consortium for Dementia Care and Prevention has listed a group of 12 major factors associated with healthy aging, including some social determinants of health, but also health factors, lifestyle factors, mental health factors. We include all of those factors. In particular, we assess factors like education, attainment, social participation, experience of social adversities, socioeconomic resources, but also we have option to measure some cardiometabolic factors like the prevalence of diabetes, cardiovascular disease, body mass index, hypertension, and we also assess other complementary factors related with mental health and lifestyle factors in order to predict the performance in cognitive, functional, and mental health assessments. We have some results of those initial analyses. In particular, we observed that individuals, adults between 21 and 65 years old, who were exposed to violence exhibited reduced executive functioning. We didn't observe differences in cognitive screening as measured by a mini-mental scale, but we didn't find we neither find differences in functional ability assessed by Bartel scale. We have also the option to assess the potential mental health factors associated with the exposure of violence by using some scales that capturing depression symptoms, anxiety symptoms, sleep disorders, fatigue, and pain. And we observed some differences between individuals who were exposed to violence. Those individuals exhibiting increased prevalence of depression and anxiety, but also difficulties in pain modulation compared to healthy controls. Moreover, we assess some factors associated with motor or sensory perceptual skills, and we observed that individuals who were exposed to violence exhibited fear of falling, difficulties in vision skills, and they have also difficulties in autonomy for walking and other motor programming activities. Moreover, they exhibited difficulties in cardiometabolic factors and increased prevalence of smoking, which is one of the lifestyle factors associated with cognitive decline. This is more or less the first approach that we assume by assessing population-based studies, including national aging survey, but also mental health survey in Colombia. In a second project, which is an ongoing project, I will show you some preliminary results that we are working in the context of the pilot project that we obtained with the GBHI and Alzheimer's Association. We assess to what extent can the experience of intense and chronic violence could affect biological aging, but also brain health measures in individuals who have been exposed. To this end, we have the option to collaborate with some researchers here from Colombia, in particular, Dr. Eduardo Herrera, but also some colleagues from Cornell University, Dr. Michael Corley. And we had the option to start to collect samples of individuals who were exposed to violence and who were victims of intense violence in the south region of Colombia, the region of Valle del Cauca, Cali, and Nariño, which is more the south and east part of our country. And we have option to assess not individuals in different lifespan stage, but more individuals in older ages. And we have some preliminary results which reveal the interesting effects of violence on some brain health, mental health, and physical health in those participants. In particular, we observed that older adults exposed to violence exhibited reduced cognitive functioning and reduced executive functioning as measured by MoCA and in ecofrontal screening. We observe also some effects in functionality, functional capacities, behavioral disorders, and mental symptoms. As you expected, individuals, older adults exposed to violence exhibited more behavioral problems, more mental symptoms, more depression and anxiety symptoms. And in a second part of this project, we were interested in assessing biological aging by using some epigenetic markers. As you know, epigenetic is a biological change that you could obtain as a consequence of exposure that you have in your life. If you have some genes of risk, it could increase the risk of suffering some disease, but these risks could be amplified or reduced as a consequence of the exposure that you have in life, including nutrition, air pollution, experience of social exclusion too, and other kind of exposure. So those exposure could switch on or switch off the regulation of your genes and express in an accelerated way some of them. Recently, it has been developed a biological aging measure by using epigenetic markers, and you could assess the degree of biological epigenetic acceleration due to different factors like of different exposures like low socioeconomic status, low education level, smoking, alcohol, and other risk factors. And we obtained some pre-existing results revealing that the experience of different kind of social diverse and social disparities could affect the epigenetic age. In particular, we observed that individuals who were exposed to violence exhibited biological acceleration, epigenetic acceleration compared to controls. They look older than controls. And for us, it was very, very, surprising, considering that it's not only an effect on cognition and functionality, but also it's an effect embedded in your biological aging systems. So just to present a final discussion, our project revealed effects and differences between people exposed to violence and controls across different lifespan, and that type of effects could impact in even the biological aging. And considering those kind of effects, we think that it's a good moment to assess how to change the current public health agenda in Colombia, included Total Peace Agenda and National Development Plan in Colombia, advocating for the promotion of brain health in those individuals. Thank you so much.
Thanks so much, Nano. And for our final speaker today, I'll turn things over to Laura Maria Calderon Cuevas, who is a Colombian musician, dancer, teaching artist, and internationalist, in addition to being an Atlantic Fellow for Equity and Brain Health from GBHI. She is also a project manager and a music-centered workshop senior leader at Musicians for Human Rights in Greece. With a master's degree in human rights and democratization, Laura has extensive international experience at the intersection of music and human rights and spent time working at the UN headquarters in New York. Laura most recently lived and worked for 8 years in Greece with refugee communities and also conducted work in Ethiopia and Italy. Welcome, Laura.
Thank you so much. Hello, everyone. So today I'm going to talk about the transformative power of arts in recognizing, connecting, and healing from war and violent conflict. So first, a very general overview about refugees. So there are 117 million people forcibly displaced worldwide. In 2015, when I arrived in Greece, it was about 1 million refugees that crossed the Mediterranean, and 85% arrived in Greece. 80% of them were from Syria, Iraq, and Afghanistan. So some of them, or most of them, were arriving by sea. And this was in Idomeni. When Europe closed the border, more than 17,000 people stay in Greece trying to cross. And these are some of the images of this region. Some men were stitching their lips in a way to protest. And it was the beginning of the refugee camps, which were military camps abandoned, and they transformed it into refugee camps, also old industries. So I went to Greece because I wanted to do a research about the development of an artistic talent as a human right. So I categorize art as knowledge and experience able to transform our reality. So I wanted to confirm this through neuroscience. So what says about music? So music helps the simultaneous integration of multimodal sensory, improving language, learning, memory, and attention, physical coordination, and development. In the sociology, from the sociology discipline, Music is a fundamental base for social communication, identity of a community, and social changes. Here I was talking about Nina Simone and her role in the Afro-American movement. And through the anthropology science is how music talks about the history of a society, cultural codes, and daily activities. I was talking about the role of cumbia in integrating the indigenous communities, Afro-descendants, and the Europeans. I also performed a survey with 155 people living in the Avatar refugee camp, which is the closest to Thessaloniki, the city where I was living. And most of them were from Syria, and the statistics reflected a trend of 86% towards a need for more cultural events, spaces to create community, express themselves, and share enjoyable moments. While I was doing this research, the military director of the camp told me that I needed to meet someone very special. This man was playing every night for his family and people in the camp. And he performed for us, and I decided I wanted to organize a concert with refugee musicians, including him and local musicians. So I contacted the main concert hall of Thessaloniki, Megaromusikis, and we organized a concert. Here is Dijar with his family, and also we invited a Syrian singer. And for them to come to this performance, we had to address many challenges, like transportation, their clothing, among other things. Here there is a video about the concert. I will only share like a few seconds of this.
A lot to me, and it's a big moment because I used to be in the camp, like playing inside the tent, and sometimes playing for my friends only, and it's like small people sitting friends together and singing and playing. But like from the tent to Migaro, this is like a big transformation, you know, which is it's mean a lot to me. It's a big meaning to me, and it's a big moment to be here. And then also the songs will be about love and freedom at the same time, and being away from home. And yes, this is my pleasure to be here, and I'm so excited for it.
Anyone who will be interested, I will be sharing the video so you can see the whole performance. So after this, I decided to start doing artistic workshops in refugee camps. And after extended research, I found this model that talks about arts as a tool to build 6 capacities and quality for individual and collective change. This is called the Productive Socioeconomic Community Educational Model from the Ministry of Education of Bolivia, when they want to create an inclusive education approach where children with diverse learning capabilities, children from indigenous communities, they learn all together, they co-create with the students, and they recognize diversity as a source of wealth in educational processes that allow the development of potential needs, expectations, and interests. Here are some of the capacities and qualities I want to address while I'm doing my workshops. First, the linguistic. Second, the cognitive logic. Third, the socioaffective. The artistic, psychomotor, and creative. Now, I will share with you some of the images. This is a community center built by some volunteers outside the camp, because every year was more difficult to enter the camps. So we were doing our activities here. We did a summer camp using like crafts, masking. We invited adults and children to do it together. These are some of the activities that we did. And we also decided to paint the walls of the camp. We invited more than 100 people to participate. We asked them to share words with the community, words of love and positive things. So this is how it looked, the entrance of the camp. And the music workshops. So we were using recycled materials. So with bottles, we were performing percussion workshops, body percussion. We were doing also singing, dancing, movement, among other things. So we also have some workshops where we invited the Greek community to participate. So here is some locals with the refugees. And I will share with you a small video of how it looked at workshop. Okay, so here are some of the quotes that they have shared with me about the workshops. Music doesn't have any nationality. Everyone can understand and feel it and put together all cultures of the world. I forgot how to write, but I love drawing and music. That's how I express myself. God gave us the heart to all of us to create and love music. And here is how the children were responding. Many of the people working in the camp told me that after the music workshop, the children that never played together were playing again. And finally, the Lullaby Project. So this project, I sit one-to-one with the mother, and I help her to express her wishes for the baby, and we to compose a song. So here we are with a mother from Eritrea and her 2-month baby, Karim, which means generosity. Here is a mother from Cameroon. Here is a mother from Afghanistan. So what has been the impact of doing these music workshops for the last 8 years? So these are some of the things I found: self-knowledge, stimulation of senses, imagination, and a perception, release of stress and anxiety, a safe space to be vulnerable and create meaningful moments, awareness of diversity, spaces to build community, recognizing each other's virtues and weaknesses with joy and empathy, and inviting the host community, and sharing time with others who do not speak the same language and look different. So finally, I want to share with you the story of Safi. Safi was born in Greece from a mother from Palestine. She was alone when she gave birth. Her husband was taken by the police, as many refugees, and he was born with different conditions, and I met her and we decided to write this song together. And for her has been very important to have this connection with the baby, because the first month she couldn't even like take him in his arms. So the only thing she could do was to sing to him. So the song says, Atamana laka sehada imawasada asalama watafia la malaki safi habibi wa hayati nafdalbi wa umer al mama safi habibi wa hayati nafdalbi wa umer al mama. My sweet baby, you are a gift from God. My sweet baby, you are a gift from God. You are the light of this world. You are the of love, my beautiful strong. My beautiful strong, yes, you are my love, my beautiful strong. My beautiful strong baby of my heart, Safi, my love, you are my life. You are a gift to your mama. Safi, my love, you are my life. You are a gift for your papa. Safi, Habibi wa hayati, nafdalbi wa mera mama. Thank you.
Wonderful. Thanks so much, Laura. And we'd like to invite all the speakers to come back for some brief panel discussion. And Camelia, I'll turn it over to you.
Thank you so much, John. And for all of our speakers, please go ahead. You can turn your cameras on and your sound on. We'd love to see your beautiful faces. Thank you. And thank you again for your comments that really walked us through the different phases of conflict, displacement, and healing as well. So we'd like to ask a question to each of you, which is reflecting on the progress that has been made. What do you see as the biggest remaining gaps in research and practice? What would you like to see if time and funding were no barrier? So it's really it's a question about imagining the possibilities. Yeah, what's left to do. And any one of you can start. Thoughts are percolating. I wonder if we might start from the beginning of our panel with Raquel. Any thoughts on gaps and possibilities?
Sure. So I think from the perspective of the invisible injuries of war, that would include concussion and also PTSD. I think that what the field really needs is really large-scale implementation research, because we already actually know a lot of what we should be doing. We should be screening and diagnosing and managing. And we learned this from the United States military over the last 20 years. But I have learned, and I'm learning still, that this is by no means universal, right? What the US military has done, and speaking even to people from other countries, these mild concussions and blast concussions are severely underdiagnosed and typically not diagnosed. And so I think, just, a large scale implementation study, to essentially screen, diagnose, and deliver the evidence-based management, which is really just patient education and treating symptoms, which improves outcomes, is, I think, the most important next step. And, we have a lot of opportunity now with emerging biomarkers, but of course that's for more resource-rich settings, right? Like, I think we can even do a lot with what we know in under-resourced settings, more than what we are doing now.
Wonderful. Thank you. Thank you, Raquel. And if I might piggyback onto that question for you and the other speakers, just because of time, what also gives you hope? So the question addresses both the gaps, possibilities of time and money were no issue, and one thing that gives you hope in your work. So if I might direct that quickly to you, and then we'll move to the other speakers.
Sure. What gives me hope is basically like finding and meeting other people who are really passionate about brain health, and having the opportunity to work together towards advancing brain health, both in my region and beyond. And so while the circumstances of my recent work is there are no words, I will just leave it at that. It's been really inspiring to be able to work with really passionate and smart people to advance brain health.
Fantastic. The collaboration, that spark in the collaboration. Tala, can we go to you with the same question? It'll be the same question for everybody.
Yeah, thank you so much. I think I touched upon this in my slides, that refugee health is really, really understudied, severely understudied and underfunded. And we looked at this systematically in different settings and looking at different disease models. So I feel there is a need for more funding in this area, definitely, refugee health as an entity. And I think I agree with Raquel, implementation science is extremely important, but also longitudinal research to even understand causality. The study that I shared today is very cross-sectional in nature, and it's the first of its kind to really try to answer simple questions such as what is the cognitive decline status among encamped refugees? So we need more of this work and more of the funding in this area. I think, again, the future looks like we are going to have more displaced people, and we need more work in this area.
Wonderful. And any thought on what gives you hope?
Yeah, it's refugees themselves, the community wisdom among these highly resilient individuals that are able to start from scratch in new settings that are very complex and oftentimes discriminatory to them and marginalizes them. I feel there's so much hope and resilience and entrepreneurship and good things to lift and narratives to lift via research, which really is where I feel my passion is as a scientist to do.
Awesome. Thank you, Tala. Narratives through research, the implementation, and the inspiration from refugees themselves. Thank you. Thank you. Nano, can we pivot over to you with the same question?
Yes, thank you. Thank you so much, Camelia. Well, I would say that it would be important not only to assess the negative consequences, but also to try to elucidate the potential resources that community have for facing those exclusion associated with violence. So I would say that it would be important to assess resilient cases in presence of violence, not only individual cases, but community strategies to face the effects of armed conflict and violence. And I would say that's a second aspect. It would be important to try to assess the intergeneration effects of those exposures, not only to assess individuals who suffer directly the violence, but also the new generations, and how the effects of violence not only impact brain health, mental health measures, but also some social measures, how they could integrate with other groups, how could be related with, how is the social participation of those individuals after the exposure of violence, not only direct exposure, but also the relatives of people who suffer violence.
Thank you. Thank you very much. And does that connect to where you find the hope as well in terms of the community strategies?
Yes, I would say that the hope is to see how the communities has fighting for trying to maintain themselves together and trying to promote some community strategies for preserving their health and social connection.
Awesome. Thank you. So you've really hit on the resilience we can study further within communities, those community strategies, and really looking to social measures as well. Awesome. Thank you. Thank you. So now we go to Laura with the same question about the gaps, the opportunities, and what gives you hope in your work and research.
Yeah. So it gives me hope, of course, the arts, like using the arts and engaging. I think there is a big gap in the artistic field. So I hope that we can engage more artists to be aware of the important role that we can play in humanitarian settings, and that we all should contribute in a way or another. Yes, this is like, let's keep singing, dancing, and I think for each of us is important, and of course for them much more. So yeah.
Thank you. Thank you. I mean, the way you've emphasized the arts, and you shared both through your video footage with your work and your own voice, and sharing that beautiful lullaby with us, that really does emphasize the power of the connection in the arts, and in this case, music. So thank you, Laura, so much. I'd like to turn it back over to John, who's going to wrap us up. And speakers, please feel free to stay on your cameras. We'd love to continue to have your faces with us as we wrap up.
Thanks so much. And we're nearly at time, so I'll be very brief. And a big thanks to all the speakers, for joining us today. Really rich discussion and a variety of talks, very illuminating to think about these very complex and challenging issues. I know I learned a lot, and I think it helps us to think about these challenging issues in different ways, from the devastating impacts of war and how that has acute impacts on the brain and brain health, but also these longer lasting outcomes from the neurological to also from the forced migration and the settings that people are continue to live in from the aftermath. But also this invisible, as you talk about, Raquel. I think that speaks to many of the different insults that people experience, but also the hope that all of you have brought to our attention as well, from the things that we've learned from the communities that we're working with. It's very inspiring, the future of where we can go and how arts can play a role in this. And I think it was actually very nice that we came full circle in our session today, with Bruce drawing on music and song to help to articulate and make sense of the tragedies of war, and then Laura closing us out with how music can be used for healing and bringing communities together. So wonderful. Thank you all. And big thanks to the GBHI team for all the support, and all of you for participating today. Camelia, I'll turn it back over to you.
Thank you, John. Just thanks again so much, everyone. You'll see on the logistics side, we have shared a feedback survey with you. We would love to hear your thoughts. I want to especially acknowledge additional team members who are part of this effort: Caroline Prulot, as well as others on our team, Kaylee Mateo, who prepared that survey, and the others mentioned earlier. We stand here united and connected as a team here on this topic. We at GBHI certainly value the work and the efforts of each and every one of our speakers today, and we hold a lot of hope together for the future and where this research and where these very innovative practices can lead us, as we always aim for global health, better health for everybody. So thank you for joining us, everyone, and we look forward to the next session. Have a wonderful day.